So it's really clear that there's quite a diversity in the ERs that are represented and the challenges that you have. And you know, I got the opportunity to talk to a Canadian physician, and they are, you know, they're seeing 30,000 patients in 7 beds, something that would be viewed as inconceivable in the United States. Inconceivable that you would do that. So we all have our challenges there. We want more patients, and my presentation to you has been trying to use a financially driven strategy that you could use to the COOs to get what you want in your department through, you know, using the terms that they like to talk about in terms of, you know, the revenue and the patient satisfaction and the medical staff's happy, those kinds of things. I just wanted to talk briefly about staffing. I think there are 2 really important issues in emergency medicine, at least in the United States. One of them is about the economics of it, which we talked about, and there's 2 issues of the economics. One of them is related to staffing. Staffing is probably the single most important kind of thing that you need to generate good throughput. We talked about processes. Processes where there's all of this movement now of getting people seen in the triage area. And you know, I'm wondering whether that's all that good, frankly. It's like, well, what's the next step? We're going to see in the parking lot? It certainly reflects to a certain degree about a dysfunction. Why can't we why do people have to be seen in the triage area by providers? Why can't they be seen in a private room kind of thing? Why can't they be seen the way all of the other patients are being seen? So the idea is we're talking about front-loading these patient processes. That's one concept that has kind of been talked about. The other part of it is related to who's going to do it. And they're always banging to us about, you know, we can't afford it, we don't have enough money, the staffing is an issue. And I want to basically go through that because these are the basic premises that you must believe in when you talk about staffing. If you don't believe in these, then you're not going to have the passion to make the case about why you are going to get better staffing. I think most of you would agree that you'd like to have more staffing. Is that really not the case? You'd like to have more. Most community hospitals are profitable. I wanted to show that. The fact of the matter is that I can demonstrate that most of your hospitals are profitable. Most of your hospitals are generating $300 to $400 to $500 per patient for everybody who goes home. But unless you know that number, you cannot make the compelling case about, geez, a tech is what is the value of one patient. One patient who goes home without being seen would have generated $400. I can have a tech in my department for $400 a day. They get paid $20 an hour, $25 an hour, totally loaded. I can have a tech for 15 hours if we had not let one patient go home without being seen. So everything needs to be converted to not only dollars, but you know, how many patients will it take to pay for this incremental benefit? So you have to agree that most ERs are profitable. We're not talking about inner city hospitals whose job it is to take care of the poor that are paid for by the community's taxes. The patient payments for services are generally high. In the LA Times, there was an article about, on November 22nd, article in the LA Times about an anesthesiologist who was injured playing touch football, went to a local emergency department, was charged $5,600 for a laceration on his forehead. The physician charge was $600. The ER charge was $5,000. That's no CAT scan. That was a $360 tetanus shot, and this is in Southern California. Embarrassing. It makes the newspapers about what this poor soul was charged. Could he afford it? Yes. Was it fair? Absolutely not. Absolutely not. We have a national reputation that is unfavorable regarding waiting and throughputs. Would you agree that's the case? You just ask any citizen what they think, and that's what they're going to say. So our national reputation is a problem, and so that's what this conference is about, is trying to fix these problems. And that we have a problem that most businesses would love to have. We have too many customers. Most people would put up billboards, coming, advertising. We don't need advertising. We get too many customers, according to most of us. Throughput is our biggest single challenge. Throughput is our biggest single challenge. Optimizing staffing in conjunction with optimizing processes are the 2 techniques that you will need to use to improve your throughput, and that the goal of the ED should be have patients the ED for as short a time as medically appropriate. And I underlies the medically appropriate because my goal of 2 hours for the average patient to be in and out doesn't say an asthma patient has to be in and out 2 hours. That asthma patient, you can give them all the treatments you want. They can be there 3 or 4 hours. You can treat the GI patient who's been vomiting, dehydrated, needs some IV fluids. They can be there the medically appropriate time. But there are a lot of people who don't need to be there any time to be observed and treated, like the cut finger or the, they should be in and out as quickly as possible. We don't want to watch the fibroblasts come together, make sure that the wound is healing properly, treat it out, kind of thing. The crying baby, got the ear infection. You don't need to observe those kids and say, yes, here's the amoxicillin, the ear infection out. So many patients they are not time sensitive in terms of, well, we have to observe how they're doing. Let's do a recheck. Let's document those things. Not at all. And lastly, and this is a really important concept, staffing for the average means that you're understaffed half the time. Take that sentence to your administrator. You staff for the average. Well, if you're staffing for the average, that means half the time we're overstaffed and half the time we're understaffed. So the question is, can you afford to be understaffed? And when you look at the economics of it, the answer is absolutely not. You cannot afford to be understaffed because you have $400 revenue opportunities that you're not going to be able to effectively address. So yes, by nature, because of the high bills that we generate, the level of expectation on the part of the patient has to be, I'm going to be able to be seen and the staffing is going to be there to handle my problems. I mean, I don't know whether you've ever heard a patient say, are there any other doctors here? Are you the only doctor here? It's clear that you're understaffed, that you're out of control. Staffing ratios. Now, some of you who are the nurse managers get this number thrown at you all the time. This number and the number is 2 to 2.5 employee hours per patient. So say you see 60 patients a day. 60 patients a day times 2.5 is 150 hours of employee hours per day that you're allotted. And that's considered to be fairly generous. Would you acknowledge that 2.5 is fairly generous? That means 150 hours of employee time to handle 60 patients. That doesn't say whether these are PhD nurses, clerks, techs, and one of the really big problems in the accounting of emergency care is this idea of full-time equivalence. That should be struck out. We don't care about full-time equivalence. What we care about is, what is the cost to see a patient? What is the cost to see a patient? Take that 150 hours of service time. What is the salary of those 150 hours? And then divide it by the number of patients seen. And as I told you before, our number was $170 per patient. Relatively high number. We are relatively well staffed because we want to have the capacity to see incrementally more patients and generating $400 a piece on those. You'll make much more money seeing more patients than being leanly staffed. There's no money in being leanly staffed. The money is seeing more patients. And that philosophically you have to take home to the administrators. This number is embarrassing. It's embarrassing. This number is around from the 70s when they used to staff ERs, when you weren't holding patients, the patients weren't as sick. It doesn't take into consideration things that even the most, any COO should understand that I can't apply this number uniformly. It doesn't take into consideration who is staffing. It doesn't take into consideration the patient acuity. You can't apply the same number. They're admitting 15%, you're admitting 25%. It's certainly not the same, and yet they apply it the same. This number is used to beat you up. And you basically have to have the skills and talents to say, well, this number is not applicable to our hospital. We're holding patients. Our admission rates are 25%. Our length of stay is 5 hours because you can't get the lab to get us a test back in a quick enough time. It doesn't take into consideration any of these things. So this is this overemphasis on costs because you don't know your revenues. And this comes up all the time. And the nurse managers get the butt of all of this. So here are our goals. We mentioned these goals before. Everybody knows these goals. Door to provider time, 30 minutes. 2 hours for discharge, 3.5 hours for admitted. And at our hospital, we put down the time of the admission decision. Dr. So-and-so said he would admit the patient. The hospital gets 1 hour to get them out after that decision is documented as the admit decision. And for every hour that they're there afterwards, we are performing floor work. And we want credit for that floor work that we're performing. And the fact of the matter is if you don't measure your decision time, you can't tell them, well, 3 hours of this stay was because we were waiting for you to get them a bed. So if you're talking about ammo that you need to know the decision time for the admission so that you can subtract that from the time that the patient was there. Everybody in our department basically gets periodic feedback in terms of the times that they're able to achieve these goals. So periodic feedback is important. Philosophically, you try to achieve these times by getting rid of serial processes. These serial processes have been built into the tradition of emergency medicine. You go to the window, you say you'd like to be seen. They say, fine, okay, go over there to the triage department. The triage department does their thing. If there's a bed available, they'll send you in the back where a tech will then see you and put you in a gown, and the next person to see you will be the nurse back there who's going to be and so the physician will be the 5th person to see you, no matter what the heck is wrong with you, because it's step 1, step 2, step 3, step 4, step 5. You cannot achieve 30-minute door-to-doctor times if you have a 5-step process like that. So the idea is parallel processes, open beds, registration. We have a registration person back in the department. You know, traditionally they're out at their window kind of thing. They register you. How do you do bedside registration? Do you do it the same way you do it as if an ambulance shows up? Ambulance patients are bedside registered. People have to get off their tush, they have to go back there with a clipboard, get the information, then put it into the computer. It is the way that all the VIPs are seen. Bedside registration is the rule. So when a person comes in and there's an open bed, you know, registration will come in, the nurse will come in. If the nurse is busy, the doctor will go in. So if the kid comes back and he's got 103 fever, the doctor may say the kid, no nurse ever saw that kid. The doctor goes in there and sees that person because they see that there's a person in the room. Okay, I'll go in there and see them. Rather than have they been going through, I'm waiting for step 4 to be completed so that I can be step 5. And I don't know about doctors in the room, but how many of you are encumbered by, you know, well, you're not ready to see them yet. You're ready to see them, but the staff is not ready to have you see them. So under this process, there might be 2 or 3 people in the room descending on that person to have these parallel processes rather 1, 2, 3, 4, 5. Right staffing, I think, is, so bedside registration, that's a given. And if you don't have room at your bedside to register the majority of your patients, basically maybe you have some issues about throughput. You should be able to take the majority of the patients who present to you and put them in a bed as they arrive. That's it. That's the goal, not to have them sitting in a waiting room. And so the idea is we got to go faster to free up these beds. You don't own your bed. We're going to put you in a chair while we're waiting for your x-ray results to come back. Anyone can start seeing the patient who's available, including the doctors. And frankly, there are patients at our hospital who are never seen by a nurse. Never seen by a nurse. Doctor saw them, here's the problem, signed them out, done. Did we meet all the rules? Nursing assessment? We didn't need a nursing assessment. The doctor did the whole thing. Comfort measures, high importance. Every person needs to be asked about whether they have pain or not, because people will appreciate being asked. No, I'm okay, thanks very much. Let's get that leg up. Let's get you feeling better. Let's get you comfortable. And then there's the scripting of the patient satisfaction. I'm Dr. So-and-so. You know, the idea of the business cards, where everybody gets business cards and passes out their business cards. I'm going to be your doctor. I'm going to be your nurse. Those little things mean a lot. There was a song, Little Things Mean a Lot. There's always this issue about, I'm closing the curtain for your privacy. I'm closing the door. You have to say the words, because they're going to be asked about, did they take adequate attention to your privacy? So you know the script in terms of what they're going to be asked in terms of patient satisfaction. So I want to address your pain. I don't have any pain, fine. Okay, the doctor asked. The doctor did say, introduced, I got a nice business card from the doctor. I got a nice business card from the nurse. They talked about pain. They talked about privacy, so that they are predisposed to answer the patient satisfaction survey positively for you. Right staffing mix, we're going to talk about this. Facilitate nurse and physician work. This is, I think, one of the biggest opportunities we have. We don't adequately facilitate physician and nurse work. I'm going to tell you a little bit that. And then the last thing is about narrowing. And the reason it's last is because it's the hardest thing to do. Now, looking at physician variability, don't even bother. You know, that's the last. Leave it alone. So here's our numbers. This is our staffing for 1 year. Look at this, $2.6 million heavily on nurses. When you look at proportion of the rest, LVNs, nothing. You know, LVNs have become out of fashion. EMTs, nothing. Clerks, nothing. Look at registration, it's 3 times higher than those other things. Total cost, $3.3 million then when you throw in the benefits, we're talking about $4 million in staffing for this department. So you divide it by the 24,000 and you start getting some interesting numbers. One of the surrogate markers of how sick your patients are is your admission percentage. Now, doctors have more sophisticated ways by looking at RVUs, but that's through your billing company. And so taking your billing company information to say how busy your department is, this is a crude marker of the intensity of your patients. There's nothing in nursing, I don't think. Is there, Gene, that talks about, you know, the severity of cases based on nursing universally agreed upon? There's not. So there is, the only things we have are percentage of admissions and RVUs. That's it. So there's our $170. And we talked about all of this other stuff. So we're talking about trying to deal with $170 or maybe less to see patients in a very short period of time. Staffing for the average, again, remember that small volume ERs are particularly vulnerable to fluxes in staffing. You know, if you're a 40,000 visit emergency department and your patient volume changes as it would day to day, you're much in a better position to handle that if you're a 25,000. And so if you're 25,000 and these fluxes are quite large, that's even more a reason why you should be staffed generously. And I'll show you the data in a second. So the capacity to manage patients by time of day, by day of the week, the idea is everybody's working 12-hour shifts, and there's many nurses there at 4 o'clock in the morning as there are at 4 o'clock in the afternoon, because in California they have these nutty mandatory staffing requirements. No, it doesn't work out. We have an ED doctor on call. We have a 1-doctor hospital department. Many of you maybe have a 1-doctor department. We have a doctor on call that can come in at any time to assist that doctor who is there. Why? Because we have the large fluxes potentially in volume or intensity. So these patients, this doctor may be taking care of some really, really sick patients, and the volume may be not remarkable, but they're all sick. Or I've got a big influx of the hemophiliac bus accident that just occurred, and I need some help. There is no financial disincentive for our doctor to call in a helper. No financial disincentive for our doctor to call in a helper. We pay our doctor $250 a day to be on call. They don't like it, I can tell you that. But in the month of October, where we had this big flu, 10 days, doctors were called back in to help their colleagues. Why? Because they were busy, their intensity of the cases were such, and they have no capacity in a 1-doctor shop for backup is, what's left is, suck it in. Everybody sucks it in. The nurses suck it in, the doctors suck it in, and who suffers? The patients do. They wait longer because you've chosen not to address these revenue opportunities. It's not because this is an active process. You've decided that you're not going to deal with it. So here's a 25,000 visit emergency department. On one day they saw 39 patients, on another day they saw 84. How could you possibly staff for this unless you have the capacity to increase physician coverage perhaps, or nurse coverage? Does the hospital have any backup nurses that they can call in? None. They don't want to pay them, you know, whatever the union says they got to pay them. Is there any clerks that can be brought down? And during the day they may have the resources, but at 8 o'clock at night you want to get some more nurse help in the ER. It's not going to happen. So who suffers? The patients suffer. And you have to remember, the nurses and doctors are also suffering. There's their jobs are more stressful, their patients are more demanding. And you have to remember that for physicians, this is a 25-year career that you need to pace yourself at. You cannot burn yourself out disproportionately. And emergency medicine people often do that. And I'll tell you a couple of reasons why that happens. But this is not unique. The numbers have gone up. Most recently, we saw 105 patients in a 1-doctor emergency department, that has a PA for 10 hours of the day. So in those cases, you need to have this backup, this safety net underneath you. But most people don't do it. When do patients arrive? They arrive around lunchtime. And then by 10 o'clock, you're basically solid for the rest of the day, 10 to 10. Fixing the staffing problems. If I were a king, this is what I would do. I would have every nurse would have at least 1 tech. Every nurse would have at least 1 tech. Well, ideally, they ought to have 2 techs. This values nurse work. This says nurses, need to do the stuff that their licenses support. The assessment of patients, the giving of medications, the assessment of the response to those medications. But when you have all nurses, the vast majority of what nurses do is not nurse level work. It's not $45 an hour level work. They're making calls for a diet tray for bed 7. Well, when you have nobody else to do it, the nurses do that. Can you put them in a gown? Nurses do that. That's not nurse level work. Can you get me a blanket? The nurses get the blanket. That's not nurse level work. So the idea philosophically is for nurses and physicians both to have facilitators, because they are the engines of the productivity of the department. And everything that should be done should facilitate their work, and nothing should encumber their work. And the way you do that is have inexpensive people support expensive people, not only in terms of their salaries, but in terms of what they are able to generate in terms of throughput. So how many of the nurses that you know have one tech for each nurse? Anybody? It's just unheard of. But if you were looking at productivity and getting this $45 an hour nurse to do the nursing that needs to be done, you would do it in a heartbeat, wouldn't you? But no. And the same thing, clerks and techs, they should be cross-trained, you know, to help out. Adjusting staffing by busy times, well, that's pretty obvious. And most nurse managers get real clever about having nurses come in at 10 o'clock in the morning and work at 10 tonight. Nobody wants to work that shift because you hit the bricks running and it's always busy. There's no lag time at all. Nobody wants 10 to 10. And the other thing that is a problem is 12-hour shifts. Any of you doctors in the room here went from 12 to 8s? Anybody did that? Okay, see the hands are about 10 hands. Would anybody go back to 12s? Let's see the hands. I rest my case. Doctors should not be working 12-hour shifts in busy departments, and certainly nurses should not. At the end of the day, working 12 hours, you're beat, the nurses are beat, you're beat, and you want to come back to work the next day, 12 hours later? No, not. It's amazing. There's an ER in our area, sees 100,000 patients, and for California, 100,000 patient ER is a big deal. There are very few of them. The doctors there went to 8-hour shifts. They said it changed our lives. Yes, do we have to go to work more? Yes, we do. We have to go more shifts. But is our attitude better in terms of how we view work? Yes, absolutely. Their attitude is much better. This is again a reflection of this 25-year career that you must protect. Doctors have a 25-year career that they must protect. You've got to do the whole thing. You can't burn out at 10 because you've been working too many hours, because you had your hand in the cookie jar and you bought that Mercedes E450, which you never should have bought in the first place. And you got heavily in debt kind of thing, and you bought this big house. We love doctors who are in debt, because doctors who are in debt can't say no. They have lost their power to say no. So I encourage all of our doctors to buy Porsches and buy big expensive houses and stuff like that. Because once you do that, I got you. I got you. And the same thing applies to nurses. Nurses shouldn't be working 12-hour shifts. They did that. So now you can work 3 12-hour shifts. What do? They're not allowed to work any more shifts at our hospital because you get paid time and a half. They don't want to pay them that. Where did they go? They go to another hospital. So they're now working 4 12s, and you expect their career, they think that they're going to be great. It's surprising that as many nurses and doctors can do this well as they do, considering the environment that they've created for themselves. And what do? The money gets sent back to the Philippines. You know, that's where the money goes when they work their 4th shift, and they won't let you do it at their hospital. There's a great picture in the Wall Street Journal of a hospital in Nigeria. Brand new hospital, totally empty, no patients. Why? Because there was no nurses in Nigeria to support that hospital. Where did the nurses in Nigeria go? They went to London, because the British were paying more. They sucked the nurses out. Where did the nurses from London go? They went to Canada. All the nurses moved to Canada. Where did the nurses from Canada go? We sucked them down into the United States. So there was this big shortage of nurses. They took them all from third world countries. But the fact of the matter is the Philippines are empty. There are no more nurses there. And their issue is there is this shortage. There is this shortage. So how do you deal with the shortage? You support the ones that are there with ancillary staff. We don't do that. We just say, oh, there's a nursing shortage. How can you fix it? Well, here's how you can fix it. Now, some of you are not going to like this, but this is true. So some people would think this is fabulous. All nursing staff department. All this. So let's put some numbers down. Let's put some numbers down. It costs $325 an hour for this team to see patients. You got one tech supporting 3 nurses. So this one tech's running around, their head chopped off, trying to do EKGs and draw blood and for the 3 nurses that they're supporting. You got one clerk and you got one doctor there. This model is $320, $400, $340. I think what the difference is $15 more. Who can see more patients? Who can see more patients? It's obvious who can see more patients. We've supported the doctor with a scribe. That scribe is $20 an hour. We supported, yes, we lost a nurse. We're supporting them with 3 techs now. So those nurses, our work is going to be, this is the nursing work we're supporting by techs at $20 an hour. Are these nurses going to be burned out and tired at the end of the day to the extent that their colleagues were when they had no help whatsoever except one tech? So this deals with the issue of there is a nursing shortage. So why don't we support better the nurses that we have? I don't get it. How many of you use nurse practitioners and PAs? You know, it's kind of the rule now. It's kind of the rule. You got to get the right person to see the patients. You don't need to have a doctor to assess an ankle sprain. Come on now. Nurse practitioner, fine. PA, fine. We have a rule. Our doctors will see every patient seen by a PA. Now, that's not a very efficient way to use them, and I know many of you have rules where PAs are acting independently, and at the end of the shift, you sign all these charts. I often went, what does that mean when you sign all those charts? I never saw the patient. My name's going to, I never saw them. The name's going to go on the bottom of this big stack. But in any case, and then Kevin's company, they have like 60-year contracts. Their policy is a doctor sees every patient, in addition to, you know, if a PA sees them or not. A lot of places say, okay, the PAs will see the level 1, the minor cases, and the doctors will see the more difficult cases. And those are the places where they sign the charts at the end of the day. Is it more efficient to do that? Absolutely. But we need to get the right person to do the job, and I think that's one of the problems is doctor doesn't, that looks like a subconjunctival hemorrhage. Is that an easy diagnosis to make? Absolutely. Does it mean that you're about to blow out an O-ring? No way. Your blood pressure is fine. It's an incidental finding. I can give you my assurance it's not going to be any big deal. That doesn't necessarily need to be seen by a doctor. A sprained ankle, twisted this, sore shoulder, all of these mechanical orthopedic things, it's not necessarily seen by a doctor. It would be great if your doctor can go in and see them and say, yes, I agree, it does appear to be a subconjunctival hemorrhage, then you're out of the room. That's it. All the rest of the paperwork has been handled by somebody else. The physicians became floating intellect. Bam, 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 bam. How many patients could you see a day if you were supported properly in terms of getting the right person to see them, getting the right person to do the charting? You go in, out, basically. I saw the doctor, very nice, that kind of thing. We are way too slow in terms of our productivity because we've allowed ourselves to become encumbered by all of this paperwork, and it's getting worse. You can do the computer medical record, fine. These people are generally well received. When you look at patient satisfaction, they get better patient satisfaction than doctors most of the time. Facilitate physician work. So basically we're going to ask our helpers to initiate pain management. Yeah, you can do some preliminary obvious tests, but don't let them order the non-obvious tests because you'll just run up the bill unnecessarily because nurses are ordering lipases on patients who don't need lipases, the kind of thing. Yes, they're going to get the tests started that really matter, but don't encourage them to order these discretionary tests because it's unfair. The doctors are paid to make the decision about the test that you need. Don't say, let's do the belly pain workup and here's $1,500 worth of tests because you didn't take the 2 minutes to go in there and decide this is really what you need and you don't need this. And this scribe thing, you know, I'm really surprised that more people haven't embraced this. This is truly a no-brainer, truly a no-brainer. It will change the quality of physician lives if you start doing this. And if you're looking at productivity, it is true a no-brainer. And every time I ask about it, there's hardly any hands go up, but those hands that go up, night and day, night and day. So you shouldn't be working 12-hour shifts in most ERs, and you should start using scribes if you were trying to create a business that's going to be sustainable and successful. So here's the conclusion. Staffing costs are not the problem, revenue is. But if you don't know revenue, all you know is staffing. Revenue is the issue. Revenue is the issue. These patients are worth much more than most of you would think. You need to increase throughput. Throughput is the issue. Generous staffing is the right because the bills are high. They expect more than you would expect in the doctor's office. This is episodic care, unscheduled. We have to have the capacity to deal with this. So be generous on the staffing. EDs cannot afford to be inadequately staffed because it will cost you money. You'll make less money if you're lean than if you're generous, because these techs are not very all that expensive. The work of nurses and physicians need to be facilitated. Honestly, it's called tech up. You got to get more techs in that department. You've got to get more people in the department who are inexpensive to facilitate the work of the expensive people. It's just that simple. It's called tech up. And this is often viewed as politically improper, because at what expense of this tech up occurring? Well, it may occur at the expense of giving up a nurse. But that nurses that are left will have their jobs, their lives will change in terms of how their work is facilitated. And frankly, it doesn't have to be at the expense of a nurse, because many of you are too leanly staffed as it is. So to put a $20 tech on, or put two $20, it's $40 an hour. It's nothing. It is nothing in terms of the money that your ERs are generating. So you know, don't be sympathetic to them. And then there's this business about trying to treat these businesses like businesses by measuring feedback and trying to excel. You want to be as good as possible. You want your customers to leave there and say, geez, you know, they took me right in. I get in and out. You know, they were really nice to me. Patient satisfaction, terrific. Of course, I'm going to get this high bill. I understand that, and we'll send it to the insurance company. But that's really what we're trying to achieve. Any of you have any thoughts on staffing? Staffing is such a key issue in our departments. Any of you done anything radical to change your staffing to say, you know, you can't work 12 hours? 12 hours, I think, is really one of the problems. No other industry allows people to work 12 hours. You can't fly a jet plane for 12 hours, and that thing flies itself. You know, doctors can work 12 hours, 24 hours, nurses can work 12, work as much as you want.